Well, I really appreciate getting to come up here and speak. I am incredibly honored to speak at this talk. I guess the truth is Ronnie's from Texas and I'm from Texas, so you don't have to believe half of what he told you. And in fact, that's why I'm going to speak to you about it. I'm just going to tell you stories today. I'm particularly honored to speak to this group. It's because of so many of my good friends. Two of my heroes are Ronnie Stewart and John Potts, and you all honor them with their presidency of this group. We're going to talk about the history of the American Board of Surgery. All of you guys remember that exciting day that maybe some of you remember it 2 or 3 times, when you were able to take the quiz, and as such, it really makes it's a marking line in your education, in that you either pass or you become an ER doc. And so you guys are here at the surgical meeting. That's exciting. I remember when I walked in to take mine, it was a muggy day in Biloxi, Mississippi, and I walked in the room, and there's Don Trunke on the bed, shirt sleeves rolled up, tie loosened, reading the paper. He kicked back. The associate examiner let me in the room. I was immediately hit by a radiograph that frisbeed across the room, striking me with the chest. And the history that I was given was, what's wrong with this patient? We give the exam a little bit different now, and I'm going to start with how it was. How it began and how it's metamorphosized into what is now the oral exam, and tell a few stories about men, and yeah, I would like to say about women, but there weren't any back then. But the story is about how they decided that quality is important, that testing is necessary to ensure quality, and that recognition is important. And although everybody talks about how the American Board of Surgery is there to protect the public, I'd like to say it's also there to protect you. You as practicing surgeons that carry the title of being board certified are clearly separated from those guys that aren't. And I think that's a real mark. So I'm going to tell you where it starts kind of with me. This is a picture. I don't know if you can see it very well on your screen. This is me as a chief resident in thinner days. This picture is relevant for a lot of reasons. First, this is my chair, Jim Thompson. He was also on the American Board of Surgery. To my right, Courtney Townsend, who is on the Board of Surgery, as chair, also chaired the board. David Herndon on the Board of Surgery. Many connections to the board through here. Danny Beecham, junior resident with me, chair now at Vanderbilt, has 3 members of the board right now, Dae Chung, Doug Hanto, and Ken Sharp has just come off as well. But the exciting part about this picture is not just the connections of many of these people who became well-known in American surgery. The program was much bigger than this, but this was back when residents had to be working all the time, so only a few could get off for the picture. But the exciting part is this fellow right here. That's Ed Poth. It's hard for you to believe, as Ronnie mentioned, I may be one of the few people out here that, I won't say I was trained by Dr. Poth, but then again, nobody was trained by surgeons back in those days. But Dr. Poth, even at an advanced age, I guess he's probably about 85 here, was still in the dog lab every day, down there feeding these goofy dogs with fistulas, antibiotics. His real forte was intestinal antisepsis, pre-colon resection. I can tell you that it was inculcated in us that we had to give that neomycin, erythromycin at 1 o'clock, 2 o'clock, 10 o'clock, and that was monitored, and he did that with those dogs all the time. So who was Dr. Poth? He was born in Seguin, Texas. That word right there, Seguin, if you're not from Texas, you'd have to understand how to pronounce that. At the end of the 19th century. He studied chemistry and physics at the University of Texas, obtaining his BS there in 22 and his MS in 23. Obtained his PhD at the University of California in 1925 in physical chemistry. He was instructor at Johns Hopkins in 27. While teaching, he earned his medical degree. He went to work in the Department of Surgery Research Lab and then went out to Stanford for surgical training. Remember, this is early 30s, the very beginning of surgical training. He worked in then he went to, after his training, he went to the University of Arkansas and Johns Hopkins, and he came back to Texas, to the University of Texas Medical Branch in Galveston, where he was director of surgical research from 1943 to 1961. He studied bacterial growth and surgical disease of the intestines. As I mentioned, it was really about how to minimize the bacterial growth prior to colonic resection. He became the Asheville Smith Professor in 1964. He wrote 160 scientific papers. He was a governor of the college from 1962 to 71. He was a surgical consultant to the U.S. Air Force. He married Gaynell Robertson in 1928 while she was a medical student at Penn. She later trained in ophthalmology and became chair of the Department of Ophthalmology at UTMB. He was president of this organization in 1963, and he died in Galveston in 1989. So let's talk about the American Board of Surgery. It was founded in 1937 by leading surgical societies to differentiate formally trained surgeons from doctors in general practice. It was formed to protect the public and improve the specialty. It's had an oral exam since the very beginning. They were called Part 2 initially, then now the certifying exam. So talking about surgical training starts back actually with medical training. In the middle of the 1800s, it was quite often for physicians to study with other docs. These became moved from apprenticeships in the mid-1800s to internships in the 1880s. By 1914, 75 to 80% of graduates completed an internship. William Halstead was mentioned earlier as being one of the precursors to our residency programs with his program at Johns Hopkins. The programs back that time were entirely pyramidal with only one chief resident. William Mayo said that residents should be at least 3 years in 1919. But there was already GME problems by 1939. There was 1,791 residency positions for 5,400 graduates. I guess they weren't funded well. So the boards, how did they come about? Well, in 1928, the AMA published a paper on standards for internships. In 1933, the AMA, the Advisory Board for Medical Specialties, had a panel consisting of this group from the National Board of Medical Examiners, the American Hospital Association, AAMC, the Federation of State Medical Boards, ophthalmology, otolaryngology, obstetrics and gynecology, and dermatology and syphilology. I put that particularly, I really like that syphilology part. I mean, that we don't think about that, well, most of us don't think about that a lot, but I can remember when I was an intern, it would be an anathema to not order an RPR on every patient that was entered. It's amazing how much our thought process about disease processes has changed. I suspect that ordering an HIV test in San Francisco would probably be a lot more common than an RPR now. Noticeably absent from this group right here is surgeons. Well, this is 1933. You can understand that the two surgical groups of the day, the college and the American Surgical, were a little bit excited about this. That very next fall, in October 34, the Board of Regents established the Committee on Graduate Training in Surgery. And the president of the American Surgical in the spring of 35, Dr. Archibald, said that the American College has proposed that we start beginning certification, but they are not requiring enough standards. We need to increase those standards. So in the fall of 35, at the ACS offices, Eve Arts Graham proposed an independent certifying board. In February, that board met at Palmer House for 2 days, February 15th and 16th. Dr. Graham chaired it. Dr. Whipple was the vice chair. Stuart Rodman, who later became chair of the exam committee, basically ran the meeting. There were 24 participants, 6 from the AMA, 6 from the college, 2 from the Pacific Coast Surgical, 2 from the New England Surgical, 2 from the Southern Surgical, and 2 from one other surgical. They divided into 2 groups, one for organization. That would establish who is going to be who's going to get to be certified, and the other one for training. These 2 committees met for a half a day on the afternoon of the 15th and the morning of the 16th. So what did they do? The first thing Subcommittee A did was cut the board in half and go to 12 from 24. I think that's a pretty uncommon thing that happens today. Every board I'm on seems to grow metastatically every time we meet. So the founders group, this is the first group of people, they're basically going to be grandfathered surgeons, were all the members of the American Surgical and the 4 regional societies, or any professor or assistant professor of any approved medical school in the U.S. and Canada who had limited their practice of surgery for 15 years. And over 2 or 3 years, applications were taken, and it totaled 1,151. So these were all the founders of American surgery. They were board certified. And then the certified group, they would have had to accomplish an internship, followed by 3 years of residency, 2 years of practice, then take the written exam, followed by the oral exam. And this process is still very similar to that what we do today. Subcommittee B, they had to establish training standards. This is remember, an afternoon and a morning, they set the standards for properly qualified hospitals and training, that each of these should have carefully directed and supervised apprenticeships. They should increase the basic knowledge in fundamental medical sciences, structured training in surgical pathology. There should be a ward service of non-private patients under the control of a director. They set standards for equipment and laboratories with radiology, pathology, and bacteriology services. They said each of these hospitals should have an adequate record system and library. There should be training conferences emphasizing unfavorable results, can you say M&M, with great importance upon obtaining autopsies. And there must be periodic surveys of the designated hospitals. This was the template of what would later become the Joint Commission. The training component was later set up as what was going to be the RRC for surgery. So these guys in 2.5 days basically set up the Joint Commission and the RRC. Right now on the board, we'd have to meet 3 years with 2 committees to decide if we're going to have coffee with decaf coffee or with tea before we can make a move. I'm just amazed by our forefathers in surgery that could accomplish so much so rapidly. So I want to tell you as we go through this story about some of the people involved in this. I'd like to start with Evarts Graham. He was born in Chicago, went to Princeton undergrad, went back to Chicago for med school at Rush. His father was a surgeon. He trained at Presbyterian Hospital in Chicago. During World War II, he was in the Army Medical Corps. World War I, he was in the Army Medical Corps and developed techniques for treating empyema. This was very common after the influenza epidemic of 1918. He became chair of surgery at WashU in 1919. He developed cholecystography. He did the first experimental works on the carcinogenic effects of tobacco, and this is what encouraged him to quit smoking. He performed the first successful pneumonectomy on a gynecologist from Ohio. He cured that gynecologist of lung cancer, and then in 1953, Dr. Graham himself, or 57, Dr. Graham himself died of lung cancer. He was said to be a pious man. He was very stern and strict, and most of the records from that day reflected he probably did more to develop American surgical education than Dr. Halstead. Dr. Whipple was born in Azerbaijan, Iran, to missionary parents in 1881. He attended Princeton as well. He received his MD degree from PNS. He was a professor of surgery there at Columbia from 21 to 1946. He began work on pancreaduodenectomies, the procedure that covers his name, in 1935. And during his lifetime, he performed 37 pancreaticoduodenectomies. The initial series, he did them in 2 to 3 stages and finally ended up with a procedure that we do almost essentially the same at this time. Although everybody's heard of Whipple procedures, he was an incredible educator. One of his best students was a young surgical resident that was really going into anesthesia named Virginia Apgar, who developed the Apgar score. So the first oral exam happened in May of 1938. It was held in Philadelphia with a 20% fail rate. Later on that year, they gave more exams at prominent medical centers, and these were given at medical centers until 1970. We'll talk about that in a bit. All the examiners were ABS directors. The exam was 2 days. You had to wait a year to retake the exam. You had to perform a hernia operation at the first setting of the exam, but after that time you could do any abdominal operation. That was the second morning. So here's the schedule. In day 1, you registered. You had clinical surgery, which means you saw patients and made diagnoses at the bedside. Then you did more quiz stuff on pathology, physiology, biochem, etc. the afternoon. The next morning you did your surgical procedure. It was critiqued quite heavily. And then you had special examinations on given parts of the body. So I want to tell a story based upon that first exam. This fellow up at the front is a guy named Dan Elkins. He was the first chair of surgery at Emory University Grady Hospital in Atlanta. He was one of the fathers of vascular surgery. He recruited this fellow over here, Fred Rankin, to be an examiner, along with a surgeon from Baltimore. One of their first examinees was this fellow over here, a Cajun, I won't use the word Kunas, that some people think is derogatory, from Lake Charles, Louisiana, who was training with Alton Ochsner. His name is Michael DeBakey. He was presented a 40-year-old male that 10 days prior had an operation for perforated appendicitis. He remained febrile with leukocytosis, having malaise, and Dr. DeBakey was brought in to examine this patient. He noticed on exam he had some mild abdominal tenderness and distension, with tenderness along the right rib cage, particularly at the tip of the right 12th rib. He noticed on his radiograph that he had an elevated right hemidiaphragm, and he correctly diagnosed a subphrenic abscess. Dr. Rankin, who was an incredible leader himself, realized that he was talking to the Dr. DeBakey that just published a paper with Alton Ochsner on subphrenic abscess. It was on their experience with 25 patients with 3,000 and a review of 3,300 patients from the literature. Dr. Rankin realized that this was an intelligent young man and so recognized that later. Dr. Rankin himself was the son-in-law of William Mayo. He practiced in Lexington, Kentucky, and later became president of the American College of Surgeons, the AMA, and the American Surgical. So this story goes further. The war broke out shortly thereafter. Dr. Rankin was called to the Office of the Surgeon General to direct surgical services. He recalled this bright young man from Louisiana, Michael DeBakey. He brought him up to the surgical offices and gave him a job, which Dr. DeBakey later parlayed into establishing some of the first mass units and surgical care at the front line. He then, after the end of the war, began establishing our VA medical centers, and then finally turned the Army Medical Library into what's called the National Library of Medicine. Dr. DeBakey said, there was no point in my life that made a bigger change than that exam. I feel that Dr. Ochsner having me write that paper and me knowing about that disease catapulted my entire career. He has since, and many of us feel that surgical research is imperative and writing your results down is imperative. So what did the exam cost? You know, we're from Texas. We want to know what that fence cost, how much you get for that cow, and stuff like that. Well, the part one, that's the written exam, was $20 back then. The oral exam was $50. So that would be $328 and $828 now. So the part one exam was $400 nowadays, and $1,100 for the oral exam nowadays. So there is inflation. It's gone from $1,150 to $1,500, and not only is it inflationary, you only get tested for an hour and a half instead of 2 days. So what happened after the first exam? So we'll go through some changes as this exam evolves until we get to today's point. So the very next year, they stopped the practical examinations in the candidate's operating room. It was kind of hard to always have a patient with what disease you wanted to operate on at some times. The exams still involved patients. They were still done at medical centers. They started adding local examiners, which were called guest examiners then, to examine with the directors. And they changed the exam, both the weighting from clinical surgery to anatomy and pathology. I'm sure a lot of you guys would really like to look at some past slides right now and be able to identify at that time what you're seeing. By the 40s, exams were held in 10 to 11 cities across throughout the year at major medical centers. The candidates were scheduled geographically. They discussed abandoning the oral exam because of some subjectivity, a discussion that continues every day to this point. I can assure you that some things don't change. So one of the people that took the exam in the 40s was William Longmire. When he completed his residency at Hopkins, he asked his mentors about taking the exams, and they said that he really didn't need to do it because he was a Hopkins resident. Dr. Longmire has an interesting story himself. He's one of a number of famous Oklahoma surgeons like Dr. Potts, Dr. Postier. Dr. Longmire was from Sapulpa, Oklahoma. He was training, went through his medical career. His father was a family practitioner there. And while he was a Hopkins resident, he took time off to go help his dad who was ailing with his family practice. Dr. Postier told me a few days ago that he said Dr. Blaylock had sent him a letter asking him if he would like to come back and resume this, or did he need to stay in Oklahoma taking care of these family practice patients. Dr. Longmire apparently wrote a letter to Dr. Blaylock explaining to him that about his family's practice was very important, but he never sent it and went back to Baltimore. There was a really exciting time there at Baltimore. Dr. Blaylock was there, Dr. Cooley, blocked on the other couple of names, but there's a lot of famous surgeons that were in Baltimore. But Dr. Longmire went out to California to practice at UCLA and established the program there. He later chaired the ABS as well. So in the 50s, it was changed a bit. The candidates interviewed and examined 2 patients in the morning. In the afternoon, they had a 40-minute session addressing these basic science as such. It still continued to use x-rays, microscopes, and cadavers. It was reduced to 1 patient in 1956. In 57, they'd stopped all live patients, and they stopped some basic science examining, but back in 58, they added it back, decided that they needed to continue to examine on those topics. Dr. Zollinger was chair of the American Board of Surgery right after Dr. Longmire. He was a famous examiner. Many of his techniques were a little bit different now. That we have rules now, and I won't say they're directly related to Dr. Zollinger, but apparently the practice at that time was to oftentimes put the a candidate in front of the window with the light shining right in his eyes. It was kind of a Gestapo technique. And Dr. Zollinger always started his questions out with how many grams of protein in her egg. He wanted to make sure that nobody could get the right question to begin with. He wanted to start everything out right. One of the famous studies about giving exams with Dr. Varco from Minneapolis was in Lexington, Kentucky in 1966. A resident walked in to get his exam. Upon walking out of the room, the chief of his service ran into him and said, "How was Dr. Zollinger?" He said it was really easy. He asked me the first question. I started the answer, and Dr. Varco started arguing with him, and they argued the whole time about the correct answer, and I never had to talk. So, by the 60s, it was changed into 3 30-minute exams with 3 teams of 2 examiners as we do today. For several years, they had a separate session in the afternoon projecting the lantern slides of pathology on the board, but they stopped microscopes in 68. I'm sure we're all pretty glad about that. By the 70s, the first oral exam happened in a hotel at the Sheraton in Dallas. This takes me back to, now all of our exams up until this year have been given at hotels. I remember one time I was given exams in Dallas. I've given a few over the years. I've done over 800 oral exams myself. But I was in the room, and back then we used to have rooms 1, 2, and 3. Room 2 was all trauma critical care and considered to be the most difficult room. Well, this fellow walks in. He's pretty corpulent. He's one of those fellows when he sits down, he's got to spread his knees because his pants has to hang over. He's older than the average resident. He's like my age, which I would have thought was old. Sits down. I mean, he was already sweating like a kid from Oklahoma trying to write a letter. He was swabbing that sweat off right there. I asked him the first question, and it was apparent it was a ventilator question. It was somebody in ARDS, and I started going through a few questions. He had no clue that one of the things you could do was like turn up the O2 when they get hypoxic. And he was getting worse and worse. It was going downhill from there. The patient's hypertensive. Finally, it was a pretty clean kill. So I said, that's enough. I handed over to my associate examiner, and he starts the question. I mean, he might as well be looking in the eye of a chicken. I mean, the guy's just sitting there. He's not moving. And finally, I said, "Are you okay?" He said, "Well, I'm just so upset about killing that first patient. I don't know what to do." Well, he didn't do too good in the room. Well, at that time, we got together after 3 sets of exams, and we'd meet with the other appraisers, and we'd talk about the candidates and make our grades then. Well, we get together, and this poor old fella, he didn't pass 1 of the 12 questions. And, you know, I looked him up later. He practiced in upstate New York, and they probably think he's Santa Claus and the greatest doc in the world, but he doesn't know surgery. They said, "Well, did you know something funny?" I said, "Well, he had his flying done. His white shirt was kind of hanging out." And I noticed that, and they said, "Why didn't you tell him?" I said, "Because I was trying to keep from laughing so hard with his answers, I couldn't say anything." We've all had many experiences with some candidates like that. I clearly remember a fellow that wanted to explore a left-sided stab wound through the right chest, said it's easier to get in if there's no blood in the way. So by 1972, we'd moved to 6 exams per year. In 1970, they had an ad hoc exam, and in 76, they talked about all kinds of changes, and the net result was after meeting and meeting and meeting for days and days, they decided to change the name and change the grading system from 1 to 10 as such. So this is another story you should know. I visited with Murray Brennan actually last Wednesday. You may recognize him. He was a young surgeon from Otago, New Zealand, when he came to New York and practiced at the Memorial Sloan Kettering. Many of you guys will recognize this fellow as Spence Taylor, and this is J.D. Ashmore. J.D. Ashmore was a community surgeon who formed the surgical residency in Greenville, South Carolina. Spence later came there and formed the medical school there, and they've done a great job. Dr. Ashmore was the first community surgeon on the board. He was quiet-spoken, real calm, asked questions in a calm fashion. Dr. Brennan sometimes can get a little bit animated. They had this fellow walk in New York. They're giving the oral exams, and he's in a gray suit, no tie, gray boots, cowboy boots. They started answering the questions, and Dr. Brennan would ask him a question, and he wouldn't know the right answers. Dr. Ashmore would ask the question, be very polite, and say, thank you, sir, thank you, sir. At the end, it was obvious that he wasn't performing satisfactorily. Dr. Brennan, thinking Dr. Ashmore is just this poor country doctor, doesn't understand the idea that this guy's not a certifiable candidate, queries him about what he thought about him. And Dr. Ashmore said, did you see his boots? And Dr. Brennan said, yes. Dr. Ashmore said, well, where I come from, the manure's on the outside. The fella flunked. But so sometimes us country folks express our failing opinions a little bit different. So in 1980, they established a complete separate committee for the CE, and we started doing dictations on failing candidates, a process which we did till a few years ago. At the appraisal section, we would dictate a small amount. We didn't dictate on the guys that passed. They're not going to question you. But on the ones that flunked, we would dictate each of the points at which they flunked about. A case book was put out at that time, which would have suggested questions in it, and you were supposed to use those the best you could. In 81, 82, Alexander Polk and Hiram Polk and Alexander Walt, it really worked on the oral exam, thinking it needed changing. They unlimited some interpretive skills session and slides. They added more structure to the case book. They to try to minimize the effect of poor associate examiners. They established a new new grading system, which went from 3, a critical fail, up to 7. If any director gave any candidate a 3, a critical fail, he automatically failed regardless of his performance on the other exams. Did a few other changes. So I talked to Dr. Polk about this. Dr. Polk's sort of a legendary examiner, as you guys can imagine. I don't know how many of you know Hiram Polk. And I said, Dr. Polk, you know, it's pretty well worded out there that you gave the exam from the toilet sometimes. And Dr. Polk's pretty straightforward. He said, damn, son, when you got dysentery, what are you going to do? You can't cheat the candidate. And so he admitted to that story. So the exams were a little more roughshod and less formal in those days. But Dr. Polk and Dr. Walt both contributed greatly to the development of our oral exam. In 1985, they revised the format with this new appraisal format with 3 rooms with 2 docs in each one. The first time this new format was used was May of this year. The candidates were scheduled for 3 successive half-hour sessions. Before, you might have your 3 sessions anytime during the day. You'd sit around sweating between each case. The 6 examiners then would meet for half an hour, discuss each of the candidates, and grade them at that point. Before this time, everybody would get together that evening, I'm sure with alcohol, and discuss each candidate's, award a high man for the day, and grade them, everybody together, even people that had not seen the candidate. The final grades were immediately produced their time, and it was run by a group leader. The initial exam was in San Francisco. Dr. Trunke was the sponsor. It included Dr. Lewis, Carlos Pellegrini, and Bill Schechter, some well-known surgeons here. The fail rate was 34%, and it was considered a complete success doing it in this manner. And we use that same format today, with the exception of that we actually make the grade in the room, not at the appraisal session. By the mid-'80s, they changed the name of the examiners from guest examiners to associate examiners. I'm sure that took 3 committee meetings. They started giving feedback on examiner grading patterns. In other words, where you'll hawk or dove. It was pretty well recognized that some people grade easy and graded not. As such. By 87, they stopped. Now, this is the discontinued delivery of the AM coffee to all exam rooms, taking only the appraisal rooms. I can tell you that particular topic would have taken like 2 or 3 days to figure out. They formalized a dress code. You had to have a shirt, a tie, and unrolled sleeves. And they still go by this today. We can take our coat off, but we can't roll up our sleeves. And they won't allow us to smoke anymore during the exam sessions. I think some people have been blowing smoke at the candidates. It's a more fair deal. So in 1991, the exams were being given. On April 26th, a Friday, 55 tornadoes touched down in one day across Kansas and Nebraska. It killed 24 people, injuring hundreds. An F-5 hit Hayesville, Kansas, came across McConnell Air Force Base, did $62 million in damage, killed 13 people at the Golden Spur Mobile Home Park. There were 17 deaths. All this is getting reporting on Saturday and Sunday. The examiners arrive in Omaha, Douglas County on Sunday afternoon. On Monday on April 29th, they were in the hotel. Dr. Warshaw, the current president of the college, was on the 13th floor when the alarm went off. I'm sure the guys from Texas went out and opened the window and looked out, because that's what we do. The people that live in that part of the country, many of them went to the bathrooms on the lower floors. and gave the exam with the candidate sitting on the toilet and they sitting on the bathtub. Dr. Warshaw said he'd take his chances in the stairwell and ran downstairs. He related that story to me. I think it's interesting about the exams in the bathrooms. Some of our candidates probably there before. In the 90s, they decided each areas 1, 2, 3, into 4 subsections, and you had to do required cases in each one. Room 1, the first question was always a gastric question, etc. The examination should only include questions from the case book. In other words, you couldn't just ask random questions if you wanted to. I won't say that's always done. I think we tend to be a little bit, we'll jump around a bit if we see strengths or weaknesses. So they put key management decisions into cases in 95, added some technique components in 97. They increased the number of times to take the exam in the 2000s from 3 to 5, and they eliminated geographical scheduling. Basically, you can take it any one of the places that you wish. The board was given exams on September the 11th. American Airlines Flight 77 struck the Pentagon at 9:45 that morning. It was a Boeing 757. All 64 on board died, with 125 on the ground. 30 miles away in downtown Baltimore at the Harbor Court Hotel, a number of current examiners were working there giving the exams. This is Bill Chaffee. He relates the story. He's head at Brown. They immediately called a meeting of all the examiners, both board directors and associates. The ones that were from Baltimore, Washington, and New York left immediately for the casualties that never came. The rest of them decided to stay and give the exams with one examiner per room, and they completed the exam successfully, and it was felt to be a fair exam. Unfortunately, none of them can get home very well. The roads were shut down, the trains and planes were shut down. There's even stories of some of the examiners buying cars to drive home. In the 2000s, they began balancing the examiner's severity and leniency. In other words, if you were a hawk, you're put with a dove. If you're a dove, you're put with a hawk. And they moved from 6 exams to 5 per year. So what's the future of the American Board of Surgery's oral examination? All of us feel like it's an important part of what makes us surgeons. We'll look at the grading system. They'll change it again when it goes to 1 to 10, 3 to 5, 5 to 6. It'll change. The size and the location of the exams. This last year we gave the exam. The OB-GYN board has an examining center in Dallas. We examined there. It was really okay. I think Dr. Polk would have a problem with it having no bathroom beside him, but the rest of us felt it was a bit better than sometimes giving the exams in hotel rooms with talking across the bed. The logistical issues of toting everything around that we need for the exam may be changed. We may go to more computerized work. There may be considerations for simulation, virtual reality, assessment of higher order skills, advancing in computer-based testing, and continuing use of IT resources. There will, of course, be new cases. Many of the cases we talk about today didn't exist in the past. Laparoscopic hernia repairs, complex repairs of hernias, all the laparoscopic things. What are we going to do about the certifying exams? If it goes to a 4+2, we're going to be testing people that have different skill sets and knowledge sets. It may be more formally linked to score. And should we do more training of the examiners, the people giving the exams? So this is the American Board of Surgery. They're a committed group of people. They do this without pay. They take weeks and months away from their practice to do this. They're incredibly fair. All they want to make sure is we have certified surgeons. I'd like to thank Tom Beester. He's a psychometrician at the board. And my personal conversations with Frank Lewis, Hiram Polk, Andrew Warshaw, Murray Brennan, Basil Pruitt, and Dr. DeBakey's sister Lois DeBakey, and Dr. Townsend, and the members of the board past and present. Thank you very much for allowing me to talk about this. I'll be happy to ask any questions or tell you a story that I don't know anything about.